examination, yes.
Good morning, respected judges and friends. This is a case of an AML presenting with chloroma that we had picked up in an outreach screening program. AML, as we know, is the second most common leukemia in children. It involves proliferation of malignant clones of immature myeloid cells, which replace the bone marrow and invade other tissues of the body. Alan Burns was the first to describe it as a green tumor, chloroma, involving the orbit, which can present to the ophthalmologist as a masquerade. A high grade of suspicion must be kept in mind as it may present even prior to or even during remission of systemic leukemias. Early diagnosis and quick referral of masquerades is important, as this is a very poor prognostic disease, and early referral can help in faster induction of the treatment. So we had gone for an outreach camp to a nearby village of our institute with a 7-year-old female came just for screening with body ache, bilateral periocular swelling since 1 month, and we found the proptosis, right eye much more. She just had associated fever and rashes with no other ocular complaints at all. The best corrected visual acuity was 6/9 and N6. Color vision was normal. Confrontation visual fields was normal. The pupils were normal. On orbital examination, bilateral proptosis was noted on Hertel's 26 mm in the right eye and left eye 21. The extraocular movements were slightly limited and painful in the upward gaze. On the description of the swelling, local examination, it was ill-defined, tender, firm swelling of the right eye, immobile, warm on palpation, associated with erythema and a greenish hue. The left eye showed a diffused lid swelling, which is much more in the upper temporal quadrant with no palpable mass. So on fundus examination, we found an optic disc edema with peripapillary hemorrhages. No obvious soft exudates was seen. I don't know if it's easily visible, but there was tortuosity as well as a bit of disc hemorrhages. The general examination, the child was febrile, irritable, with rashes all over the body as well as pallor. Peripheral blood smear examination was done. Initially, the TLC was within the normal range, 7,400. The GMSA stain, however, showed the blast cells. A provisional diagnosis of bilateral infiltrative optic neuropathy with underlying leukemic orbitopathy was done, and the child was referred to the pediatric oncologist with confirmation on biopsy and neuroimaging. Discussion-wise, leukemic orbitopathy is rare. It occurs only 3% of AML cases, which in itself is a rare type of neoplastic disease in children. Most common presenting feature, however, of AML is proptosis in children with infiltration of the extraocular muscles. The differential diagnosis would be an orbital cellulitis, rhabdomyosarcomas, optic nerve gliomas, lymphangiomas, and thyroid orbitopathies. In a 12 case series from LVPI, only 2 patients over a period of 10 years had been reported with optic neuropathy as well as the hemorrhages. The pale-centered hemorrhages, classically target hemorrhages, are important features. The prognosis is poor, but it is reported to be better in those with extramedullary presentations. It is a rare masquerade. The peripheral smear should be performed as a take-home message in all children presenting with bilateral sudden proptosis, and a quick referral should be done. This can be picked up even in an outreach program, which is the highlight of a tertiary center sending out camps. These are the references. Thank you so much.